All right, key concepts. I'll go through some of these pretty fast. Risk travel in clusters. Here's some of the risk factors that we look at and we talk about a lot. Often you find people measuring cholesterol, HDL, blood pressures, and so forth. Those are easy to measure. But we find that perceived health, how do you feel about your physical health? 68% of the time, that risk factor travels with 4 other risk factors. That makes them high risk. We did this study because we were interested in who are the high risk people. Who are the people with 5 or more? You saw how expensive they were. Who are those people? It turns out they have poor perception of health, they have poor perception of life satisfaction, they have high stress levels, they have poor job satisfaction. Those are the ones that travel with high numbers of other risks. It's not cholesterol and blood pressure. It's easy to do them because that's the medical model. That's how we're easy to measure, and you should do it. I'm not saying don't do it, but we got to pay attention to the high risk people. I mean, the high risk people, and those are the people with the psychological clusters. So a cluster analysis, and we thought about how do we stratify people so we're not treating everyone the same. So when you stratify people, the first cluster we come up with is a low risk or maybe a disease cluster, a low risk cluster, risk-taking cluster in this case. They smoke, they drink a lot of alcohol, they don't exercise, they don't wear their safety belt, just risk-taking people. They do a lot of activities that they don't see any immediate feedback, but they're high risk. Then there's the low-risk people who have very few risk factors. And the biometrics cluster, which we also call metabolic syndrome in a lot of places, these are the people with high blood pressures, high cholesterols, low HDLs, high triglycerides, waist circumference of over 40 for men, over 35 for women. Those are people that are in this particular cluster. Then there's a psychological cluster, the poor perception of health, poor life satisfaction, poor job satisfaction, stress or absent a lot. So those are 4 groups we can put people in. And I asked you, thinking about risk factors, when people do health risk appraisal, often they go to high risk and try to help the people with high risk. For example, body weight. People with high body weight are picked on a lot, almost as much as smokers. But you've got to be very, very careful about people overweight. Because in this case, what if somebody is overweight in the biometrics cluster? What disease are they likely to be headed for? Diabetes or heart disease. What if a person is overweight but it happens to be in the psychological cluster? What disease are they possibly headed for? Depression or mental health issues. So you want to be very careful how you intervene with these people, how do you talk to people, because the same solution is not applicable, not equally effective in biometrics cluster or psychological cluster. You have to be very careful about how you talk to people. And when you look at overall risk, the most risks, as you already know from the previous slide, all risks are the psychological cluster 4.4 risk factors average. And the low risk people are probably really low. And the high risk people are also most expensive, and that's the psychological cluster with biometrics cluster right behind. All right, let's change the subject a little bit and look at productivity. Most of you in this room came here with the idea we're talking about healthcare costs, because that's what you just found out about. But that may be missing the boat if you just focus on healthcare. That's not getting to the total value of health. What is the value of health? I don't think the value of health necessarily is to avoid healthcare costs. The value of health is also to facilitate high productivity. Here's some measures we took at Bank One. The medical costs turned out to be 5% of the total value of cost. The time away from work measures like short-term disability, long-term disability, workers' comp, absenteeism are a significant part. But maybe the most important part is how effective are you when you're at work? When you show up to work, how good are you? Do you show up on time? Do you take excessive breaks? Do you have mental lapses? Do you mind wander? Do you think about other things? Do you get tired by 2 o'clock, you can't work? What is it that takes away from your productivity at work. And that's called presenteeism. And that may be the highest contributor to overall value of work. Well, look at the time away from work measures. Here we took this is a steel case company in Grand Rapids, Michigan. We looked at how many people, the low-risk people, how many people, what was the cost for workers' comp, short-term disability absent, and then the average cost. Here's the medium-risk people, here's the high-risk people, here's the high people. Risk factors are driving time away from work measures. The same risk factors driving all these. I tried to make that point before. Here's the risk factors that we're measuring. High-risk people are always high-cost people with medical. This is medical and pharmacy. High-risk people are always more expensive, except for alcohol. And probably alcohol because it's self-reported or underreported. And people with alcohol, they don't go to the doctor. You know, why do you go to the doctor? They're just going to tell me I'm drinking. So I'm not going to, no sense to have that. Here's the disability costs. High-risk people are more expensive than low-risk people in disability. All the disability time away from work measures that we showed you before on steel case. And here's presenteeism, the call center operators. High-risk people are more expensive than low-risk people. The same risk factors are driving all these costs, the costs you face every day. And what are you going to do about it? You have only got risk factors. You have a job culture that you're trying to shape, like a healthy culture. You can work on these. Another way to look at this, excess costs. Here are the excess costs. I get the low-risk people, and here's the numbers for low-risk people in this particular cohort of populations, $2,100 for low-risk people, annual medical pharmacy costs. The high-risk people are $5,520. The difference, which is $3,321, the difference is the extra cost due to extra risk. Excess cost due to excess risk. It's a very important concept in thinking about risk factors and costs. That's medical costs. Here's disability costs, excess cost due to excess risk. Here's presenteeism costs, excess cost due to excess risk. Now, notice the low-risk people, they lose 14% of the time presenteeism. And that's a good point because I try to be 100% productive one day a couple of years ago. I'm still exhausted from it. You can't do it. You cannot expect everyone. So you have to have time. You have to expect there's going to be times when you're not, you worry about dry cleaning, you worry about your mother, you worry about your children, you worry about a lot of things. So things that, but you can control a lot. And a lot of this is due to risk factors. Business concept, stratify the population. It's my bias because I think something about this. I think you can do something about health risk factors driving costs. That's key. That's absolutely key to the concept. How far out ahead of that curve can we get? How good is the tools that WEA Trust are using? Well, here's how good they are. 83% of the time, when we predict that people are going to be high cost, 83% of the time we are right. 2 years ahead of time. 2 to 3 years ahead of time, we are right. We know who those people are. 17% of the time are false positives, so we're not perfect. You look at the bottom line, 7% of the time when we say they're going to be low cost, we're wrong. They turn out to be high cost. So that's 7% false negatives. But that's pretty good in this kind of a field. That's using health risk appraisal data. You know what your risk factors are. We know how to intervene with people. We got to do it. Change your cost, follow change your risk. What if you do this? What if you do this and you facilitate an environment where people change? Not everyone needs to change. I'm not promoting risk change at all. I'm saying facilitate an environment where people decide if they want to change, they change. Well, here's a case of people. The people on the right, their risk increased, and look at their costs. Their costs went up. People on the left, their risk decreased. Look at their costs. Their risk went down. Costs went down. What this shows you that when risk change, costs change. And they change in the same direction. When risks go up, costs go up. When risks go down, costs go down. And that's medical and drugs. Here's productivity, presenteeism. When risks go up, presenteeism goes up, that means it gets worse. When risks go down, presenteeism gets better, that means it gets better. So risk and costs are changing in the same direction. We put a cost number to this, it'd be the same thing. So when risks change, things move in the right direction. Here's something that really surprised us. We hardly ever get statistically significance in medical claims data over a short period of time and with small numbers of people. But in the green line, you'll see here's some people who took health risk appraisal in 2001 and then again in 2002, 2003, and 2004. And we looked at their costs. And they're pretty flat. That those people either did not change risk or they improved. The line are people, the same people they took, different people, they took health risk appraisals in each of those years, but their risk didn't improve or they got worse. And we got a statistically significant difference. It's all you have to do is tell people, don't gain weight. Exercise a little bit. Just don't get worse than you are. Just stay the same. A key belief I asked before, you maintain low risk behavior. If you do that, your costs will moderate.